Now, in terms of the outcome, when obviously we get to when we do surgery, because the first line treatment is medication. And medication could be Tegretol, could be Neurontin, Lyricon, the wide baclofen, there are type 1 medication or stage 1, and then you can go to different type of medication. Usually, when a patient comes to me with 2 or 3 different medication, each above 1,000 milligram a day, and they still not happy or have a poor quality of life, this is already an indication for surgery. But you want them to have responded at least temporarily to medication, because that is a criteria of I would say, is almost a confirmatory criteria that your diagnosis is correct, that yes, this is an essential trigeminal neuralgia. What I'm describing to you is a textbook description of trigeminal neuralgia. The patient that you see in the office are not necessarily a textbook. And you will see throughout the medicine, you read something on your textbook, you might know all your medical, like Harrison textbooks, Cecile, whatever, by heart. But then you go and sit in the office, patients are not representation of textbook, not necessarily. So you have to make your judgment, what is closer to what. So you will see in trigeminal neuralgia, there are variable and variety of presentations. So you have to make it up to see, does it make sense for this to be a trigeminal neuralgia or not? Now, once it is, you would like this to respond to medication. So a neurologist send me the patient, and if the patient tells me, oh, they got me on Neurontin, was perfect for 2 years, but now is not responding well, I have to increase the dose and I'm getting drowsy and I fall asleep when I'm driving, that's a good sign. At least the diagnosis is correct. If someone's coming to me, like imagine a 25-year-old woman come to me and says, well, listen, I have this trigeminal neuralgia, my dentist diagnosed it, and then they put me on Neurontin. Now I'm taking 2,000 milligram, it doesn't help at all. That's a red flag. Age is not good, doesn't respond to medication. Even if the MRI shows that there is a vessel, I have to be very cautious before opening this lady's head to do the microvascular decompression for the trigeminal neuralgia or any other type of surgical treatment. Now, if we want to see what or who are the patients who respond better to treatment, once you decide that, okay, medical treatment failed for this reason A, reason B, reason C, doesn't work for some reason, does not work anymore, the dose has to be increased, and the patient is exhibiting sign of side effects, and or if the patient just doesn't want to be on medication anymore, says, well, I'm tired of this, I'm taking this medication for 10 years, is there any better treatment? Then we get to options for surgical treatment. Now, the prediction of outcome, obviously, if you have an obvious vascular compression and the more severe it is, the higher the chance of improvement, at least based on my experience. And if the compression isn't by an artery, is much better than if it's by a vein. And if it's a type 2 pain, which means a patient who does not have that excruciating pain, but that constant pain, sometimes a burning sensation with it, and it's always an annoying pain between like a 6 to 8 by 10. And in that particular patient, if there is no neurovascular conflict found at surgery, I think that's a predictor of, unfortunately, bad outcome. The same as very young age. Usually, I'd rather not to operate on very young patients. I have operated, unfortunately, most of them have done well, but that is usually a category of patients who have a high risk of not having a good response to trigeminal neuralgia. So they have to be selected very carefully.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.